how important that sector is in our lives and in the growth of our country. We have two distinguished civil servants from this ministry. They found that they were supposed to come, but they are delegated two commissioners to come and to present her.
Karibu sana.
And Mukawara, please, both are commissioners. One is the Secretary of Health, another one is the Commissioner of Planning, Policy and Planning. They are going to take us through as they have prepared. I need us to listen carefully, write down the important things that we have picked, and we can start bringing in those questions early so that they will have time to respond to them. Yes, one. Are we there? Someone who starts in the morale. Yes, we are going to write down, listen very carefully. There are going to be two phases. One commissioner will come forward and introduce the presentation, and later on, his colleague will come in to go into the details of their presentation. So let us write our observations, our concerns, and any questions that we might have, so that we can receive them early, give them time to respond to them. Then I will also allow some fixed questions at the end. Those who, since you are three blocks, I will ask 1, 2, and 3 from you. Dear Commissioners, here in front of you, the audience is comprised of NRM chairmen all over the country, district chairmen, deputy RDCs from all over the country, and deputy state commissioner. They are here to listen to you. Be careful in your presentation. They don't want to entertain any lie, because they know what is happening. They are not going to entertain what you want them to hear. Not tell them the facts because they know they are on the ground and they will learn. So that we can come out of this with a proper analysis of how far we come. Thank you very much. Can I invite you to address the
thank you, our Central Chair. Apologies, I've forgotten the name. My name is Richard. Allow me to address you on the protocol that has already been mentioned as leaders. I know you are coming from different constituencies, but allow me to still address you as leaders. I'm also privileged this morning that I've interacted with some of you in the course of my work. And as we had already been introduced, myself, Dr. Richard Mugahi, and my colleague Chris Mugarura, we are here to present to you a presentation from the Permanent Secretary. She sends you greetings and apologies at the same time. She could not make it because of another critical engagement that came around. We intend to move a little faster so that we can spare some time for interaction. Just like the session chair mentioned, that we want to speak the truth, but nothing the truth. As you're all aware, health is fundamental, health is economics, health is politics. So it's a fundamental human right for all of us to be healthy, and that's why we come here today, to address you as leaders, pick your thoughts on where we've not done well, provide feedback on some of the key issues that we are able to provide feedback on. But collectively, we all have a duty as Ugandans to make sure that we are healthy individually, but also healthy as a country. Our presentation was informed by the commitments of the NRM government for the last 5 years, the mandate that is coming towards its final time, and that's what we shall address ourselves mainly. But as a preamble, because of that guidance that we are given, we may not touch every part of the health system. I wanted to highlight in our introduction that the health system, and allow me use this board also. You know, it has been with a lot of historical. So I just wanted to make this preamble so that it guides us as we dive into our discussions. The health system is made up of blocks. It's a system. If you have one component of the system not functioning, then the whole system malfunctions. So this system has majorly 7 blocks. 7 blocks. And I wanted us to begin with these blocks of the health system. In basic science, like the body, let me say like the breathing system, we call it a respiratory system. It has different parts that work together to produce a given function. So the health system also has different parts that work together to produce a given function. And your presence here, you also fall in one of the blocks. One of the most important blocks of the health system is leadership and governance. Leadership and governance. The second one, the second and equally important block of the health system is health infrastructure and equipment. I will explain a little why we opted to tell you this. The third one is health health human resource. The fourth one is health financing. The fifth one is health information. The sixth one is service delivery. Health information is the same as data. The sixth one is service delivery. And the seventh one, which appears as the newest, 7. The seventh one is community. So I felt that this should be at the back of our minds as we dive into our presentation today. We've been so much limited in our request to present. We've been limited here. Health infrastructure. We shall talk a little more about the health supplies, health financing and supplies. We shall talk about health supplies. Then we might not talk about the human resource, and then the role of the community and leadership in our presentation. So as we dive into our achievements over the last 5 years or 4.5, we are going to brief you on what we've been able to do, what we had planned to do, and what we've been able to do. Importantly, in the area of infrastructure and the area of equipment. But all these blocks are coordinated to produce an output broadly here, an output here, which is service delivery. So at the center of all these building blocks, we have service delivery. This is actually drugs and supplies. Doesn't work. Drugs. And drugs and supplies are very critical in our discussion today, because drugs are a very critical component of our work, and that is what we shall be able to explain to you. In line with that, those are the thematic areas. It's very difficult to see. And these are picked from our manifesto commitments. We want to curb theft of medicines. We want to reduce absenteeism in health facilities. We wanted to increase availability of medicines. I'm coming from up down. We wanted to increase functionality of hospitals in every constituency. Wanted to upgrade health center 2s to health center 3s. We wanted also to construct construction of health center 3s and improve the status, construction of health center 3s and provide the status of sub-counties and town councils without any health facility. We also wanted to provide installation of oxygen as a medical commodity. I'll request my colleague to come and run through the slides, then I will come back and provide the achievements. Please step forward, Chris. Better stand out here. Do you want to go through this?
So, we go direct there. Maybe summarize the statistics. Let's summarize. So, morning, ladies and gentlemen.
What is this?
This?
I thought it was this one.
So our fellow RCCs, RDCs, deputy RDCs, district NRM chairpersons, the leadership of the National Leadership Institute, and our colleagues from the Manifesto Implementation Unit, which is directed by my
OB, Mr. Willis Bashasha. I'm pleased this morning to make a presentation on behalf of the Ministry of Health, as now you know we have shifted from this concept of calling ourselves a sector. We are a sub-program under the Human Capital Development Program, which has 4 ministries. It is headed by the Ministry of Education and Sports. That's our chair under the Human Capital Development. Then the Ministry of Health, co-chair, Ministry of Gender, Labor and Social Affairs, and then the Ministry of Water and Environment. So I'm presenting the component of the health sub-program on behalf of the Permanent Secretary, who unfortunately could not make it, but she's ably represented. I think I will have to stand this side to read properly. So they have already highlighted the structure of the presentation, the themes of the presentation, as per guided by the manifesto, the NRM manifesto of 2021-2026. So I will start with the installation of oxygen plants in regional referral hospitals. And here I'm happy to report that the government procured 24 high-capacity oxygen plants that have been supplied and installed in all the national and regional referral hospitals across the country. And currently, the country has a total of 48 oxygen plants with the capacity to produce 5,000 cylinders of oxygen per day.
Asante sana.
And this capacity is able to meet the country's current oxygen demand. This is the distribution by region, oxygen plants by region. Northern Uganda, 7 of them have been installed. Western, 10. Eastern, 9. Central, 22. In total, there are 48.
Asante sana.
Come again. Come again. It will come later, but they are mainly in the regional referral hospitals. Then, next. This one we have finished. Then on construction of health center 3s in sub-counties and town councils without any health facility. I'm going a bit back from 2018-2019, when we had a government program under the U-Gift. I'm sure you people from local governments, you are conversant with the U-Gift program and the AMCHI project. So from 2018 to 19, you remember that we had 132 sub-counties and town councils without any health facility, that is Health Center 3. But to date, 31 new health center 3s have been constructed, equipped, human resources put in place, and the necessary medicines and supplies provided. The distribution per region is presented in the table below. You want to? Here it is important to note that because of the need to bring services nearer to the people, new sub-counties and town councils have since been created, enlarging the number of sub-counties and town councils without health center 3s to 488. 488 which is
Without.
because of the creation of the new town councils and the sub-counties, which is around 22% of the total sub-counties and town councils. And additionally, 81 health center 3s have been upgraded across the country by the construction and equipping of new maternity wards as per the table below. In northern Uganda, we upgraded 14 health center 3s, western 31, eastern 30, central 6, bringing it to a total of 81 health center 3s. This is and with this intervention, the access and coverage of primary health care has significantly improved, where 1,696 out of the 200.
The team here, Chair, the team here is obstructed by him. Can't you present well seated?
I'm creating a shadow. And if I stand there, there is some light which. Okay. What?
You can sit here just like a priest.
Okay.
You sit.
I can even stand. Okay.
Chairs for you.
Okay. I stand. Okay, it's okay.
Help me get a few chairs out so that he has space to move around. You can put them here.
Okay, asante sana. So with this intervention, the access of PHC services has improved, and we are at around 78% of access to primary health care services. This is a typical pictorial presentation of how our health center 3s and maternity wards look like. Let's move. On general hospitals, here, you will note that initially district hospital, what we call general hospitals, were designed to serve a population of 500,000 people, 500,000 people. But per district, the old districts. But because we have continued creating and splitting more districts, now some districts have as low as 150,000 people. So they were designed to serve a population of 500,000 people. Here it should be noted that with the split of the original districts, a number of districts now have population less than 500,000 people. So the government plan is to provide a community hospital per district, which will be upgrading health center 4s in the districts with no general hospitals to serve as a community hospital per constituency. General hospitals will continue to serve as referrals for a cluster of districts. For example, if you are in Greater Masaka, a hospital in Masaka can serve as a referral, whereas districts which were subdivided from Masaka, like Sembaule, Raka, Chotela, will have what we call community hospitals, which will be upgraded from health center 4s. In terms of functionalizing the existing general hospitals, the government has undertaken comprehensive rehabilitation of the following hospitals as a way of facilitating efficient healthcare delivery. In central Uganda, Kaworo General Hospital has been upgraded. Continue. Go back. Gombe Hospital has also been upgraded. Continue. Technology. Then we have Kasana in Ruero. It's also being upgraded.
This is Busorwe.
Busorwe in Butareja.
Complete.
It's complete. Can't they do it manually from there? Kapchorwa, that's eastern Uganda. Kapchorwa in eastern Uganda.
It's a theater block.
Continue. Then we have Jinja Regional Referral Hospital. A standard ICU has been commissioned at Jinja Intensive Care Unit. In northern Uganda, we have, this is West Nile. We have constructed a regional blood bank in Arua. Then Koboko is also under construction. It's a general hospital. Then we have Lira Regional Referral Hospital, Guru Regional Referral Hospital.
This is a lab.
This is a laboratory under Lira and Guru. Then Kambuga in western Uganda. Go back.
Guru is coming in the cancer cell. Guru is coming cancer.
First go back a bit.
There is no Guru, this is Lira.
There is Lira. Guru Regional Referral Hospitals had its infrastructure expanded. Guru is here.
No, this is Lira.
There is Lira, then there is Guru in the narrative. It's a narrative. It's in the narrative. Continue. Then we have Kambuga. Then the regional blood banks. We have so far commissioned 3 regional blood banks. This is Hoima. We have another one in Soroti.
Ready for commission.
Ready for commissioning. Ready for commissioning. Ready. Then these are health center fours being upgraded to community hospitals. We have
this one has been made a general hospital this year.
Rukochi Health Center 4. It's continue. Then we have Mitoma. It's being upgraded to a general hospital. We have Muko. It is being upgraded to a general hospital. Kabohe in Shema. Continue. Then functionalizing health center fours in every constituency. Happy to note here that there are 365 health sub-districts in Uganda, out of which 230 have health center fours, functional health center fours. 230 public health center fours have functional theaters and the required medical buildings. The process of establishing health center fours, stroke community hospitals in constituencies without health center fours has started. Currently, what is it? Currently, there are 18 health center 3s being upgraded to health center 4s across the country, with the distribution as per the table below. Continue. So these are the health center 3s which are being upgraded to health center 4s. In the north, should I read? In the north, we have a term health center 4 in Amortar. Health center 3 rather, it's being upgraded to 4. Akokor in Apache, Obel in Irila City, Ongicha in Irila City, Awele in Padel, Olivu in Arua. Those are 6. Then in Western we have Bufundi in Rwanda district and Kasita in Kapumiro, being upgraded to Center Force. In Eastern we have Namaru in Nakapiripirit, Ngogwe in Buhikwe, Nabieso in Kwania, Bubunji in Bududa, Merekit in Tororo. Those are 5. And in the central, we have Ngogwe in Buhikwe. It's repeated. That one is repeated. We have Butemba in KYANKWANZI. We have Kasambia in Mubende. Other major health projects achieved during this manifesto period. Construction of staff houses for health workers. So far, a total of 1,000 staffing units have been constructed and over 1,000 old staff units renovated. We have an appendix which has the details of these, in which district and in which health facilities. Completion and commissioning of state-of-the-art national medical stores at Kajansi in Wakiso. This was commissioned. Then increase access to specialized health care services and construction, rehabilitation, and equipping of hospitals and super specialized centers of excellence. So we are upgrading the physical and technological infrastructure at the Uganda Heart Institute. The status is that the Uganda Heart Institute was allocated 10 acres of land at Naguru by the Uganda Land Commission to construct a new home. So far, the government has signed the financing loan agreement of USDs 70 million for construction. Construction contract was signed in December of last year, and the construction was launched on 4th February. Then on cancer centers, regional cancer centers, we have one in Arua, in Uguru, in Jinja, and Barara. The status is that construction and equipping of these regional oncology centers in Uguru, it was completed, and the facility commissioned in 2023. Mbarara and Bale, continue. This is Guru, which we are waiting for. Then Loboa, work is ongoing at 45%. This is the structure. But I'm informed that now it's
75.
Beyond this.
75 now. Loboa, we are 75 and will be ready by the same.
That is the structure. Finally.
Finally, it is out. No, it's much. This was taken quite early in the year.
This was last year.
But now it's at 75% and it should be ready
by December this year.
Okay. And this part of Loboa,
the training. Asante sana. Kayunga and Yumbe hospitals were upgraded to regional referral hospitals, and the construction and rehabilitation of these two, Kayunga and Yumbe, were completed, and the facilities upgraded to regional referral hospitals. Then equipping of 6 regional referral hospitals at Guru, Mbale, Hoima, Bombo, Kauro, and Moroto with CT scans. CT scans. Go back a bit. The status is that 14 regional referral hospitals, which I'm not going to read, have been equipped with CT scans. Kayunga, Yumbe, Bombo, and Kaworo are yet to be equipped with CT scans, pending the availability of funding. This is the distribution. Back a bit.
CT scans where they are.
We have in the north, there is Rira, Guru, Arua. In the western, we have Hoima, Mbarara, Kabara, and Fort Poto. Eastern, we have Jinja, Mbare, Sorota, and Moroto. Central, Satentebe, Mubende, and Masaka. This is a typical regional blood bank, the design of a regional blood bank, which have been constructed in Arua, Hoima, and Soroti. Then supply and installation of intensive care units. Happy to note that 14 regional referral hospitals were equipped with the intensive care unit equipment. You can see the hospitals where they are distributed. By region, in the north we have 3, western 4, eastern 4, central 3, total 14. This is what it looks like. Continue. Ambulances, the National Ambulance Network. Type B ambulance. Maybe, Doctor, you can explain what type B means.
Thank you, Chris. We also brought your information that we have ambulances. Type B is the one that does not have an ICU. The cruisers, the land cruisers that you usually see, but not the ones of politicians. The ones of politicians are unclassified. So this type B is the usual normal ambulance. Traditionally, the land cruiser, it has a bed and it has some equipment inside there to support life. Type C is actually an ICU. Type C, which you see here, we have 11 of them. Type B, we have 256 ambulances, and those all of them have been achieved in the last in the whole country. These are new actually. In the last 5 years, they are active. Okay, the ones with the cards, 256. Now, the 11 are moving ICUs. They can support life. Someone who is not breathing can actually move in the 11. We have ambulances that can support life. You can see there are few. Our target is to have each region have an ICU ambulance. This can support life even if you are in Arua, they bring you to an ICU in Kampala, still with a life support system. The 14 are marine ambulances for the districts, which are in the islands, I think Toroko, Mayuke, Kalangala, so many of them. You've seen, even in Bunyonyi, you've seen a couple of them. And now, I wanted to add this narrative that the ambulances are centrally coordinated. We are giving them 2.5 million card quarterly. Every quarter we give them a fuel card of 2.5 million. We know it's not enough, but that's what we can give us for now. Based at the hospital. So when you're explaining as leaders, you'll find a challenge. People will say our hospital does not have an ambulance. We are giving an ambulance to the constituencies. The constituency can decide whether to position this ambulance at the hospital, but the ambulance will come with the constituency name. So it will be Bunyangabu, it will be Toroko, so the ambulances bear the constituency name. And I can say this very fast. Increase the availability of medicines in health facilities. We want to thank His Excellency the President. This financial year we are in, he added 139 billion towards the boosting of drugs and supplies. I think that one deserves a clap. 139 billion towards drugs.
Asante sana.
So we've made significant strides, and as you'll probably give honest feedback, that now drugs are available. I was actually in Kasese yesterday. We have even overstocks of some commodities. So one of the key areas we wanted to see how do we increase funding. So you can see here, the funding for health center tools increased by 52.8%, regional referrals increased by 54%, and all the other facilities, the funding increased by similar percentage. We are encouraging that if one facility is overstocked or if one district is overstocked by a certain commodity, they can do a redistribution. We have guidelines on redistribution strategy, so it is allowed for one facility to borrow what they don't have from another facility, but with proper documentation. That is what we are calling a redistribution strategy. We are engaging our partners like Global Fund to support us on reproductive health commodities. Under here, commodities, I want to say the message that we want to give you is that we have enough ARVs. There's been a lot of contention, people, some members of parliament calling us, do we have ARVs for the country? We have enough ARVs in the country. No one should be denied treatment. We have enough of the commodities for the coming 1 year. We are covered, fully covered, whether without American money. And we also want to mention that in some districts they have excess of anti-malarials, because of the mosquito net distribution that we participated in. So that's also a very key area in terms of commodities, and we are encouraging them either to return to the center or to redistribute. Supply chain optimization, we have strengthened logistics management by forecasting, and this has led to improved availability. Our stock availability now is in around 80% in the health facilities. Stock availability last year was very bad. NMS was not delivering on schedules, but now our stock availability, please go back and cross-check, stock availability is above 80%. In the next steps, what we've been able to do to make sure that supplies are available, one is to strengthen the national supply chain through digital tracking and predictive analytics. Our predecessor here talked about analysis. So we are able to predict that now the rains have started. 3 weeks after the rains, malaria will be coming in. So we are able to predict and stop enough malarials and make sure our population is covered. Enhanced domestic pharmaceutical manufacturing. As you have noted, a number of pharmaceutical industries are now opening up in Uganda, and we are carrying out the BUBU, Buy Uganda, Build Uganda. So most pharmaceuticals, it's very likely that if you are producing from abroad, we don't buy from. So we are buying locally made medicines, and this has enhanced pharmaceutical industries coming in Uganda. Increasing funding allocation to further close the funding gap. I had mentioned about that. The President allocated us 139 billion shillings. One health approach implementation of the new name, community hospital. If you had a health center for now, it's called the community. The new name, community hospital. If you had a health center for now, it's called the community hospital. Strengthen the whistleblower protection and reporting mechanism. We have, and we want to use more of your system, especially the internal security, to get us whistleblowers. This is more of intelligence information that we saw drugs being taken from point A to point B. Increase community engagements to enhance transparency in medicine distribution. Now that we have medicine, our communities used to go to hospital whenever they see the lorry coming, because it was like starvation. They used to come and stock, and the malarials are predicting that they are going to fall sick. But now we have enough. They no longer come in big numbers to go and stock at their homes. But you need to continue educating them that the drugs are available all through and all the time. They don't need to stock drugs in their homes. We still have this big monster called absenteeism in health facilities. We need you. We need you. We need you here. The government of Uganda, in this Chisanja, the government of His Excellency the President, enhanced health workers' salary. I think our enrolled nurse is paid a very good salary. They earn 1.1 million shillings. That is net. An enrolled nurse. So that's the lowest paid cadre. And now what we are saying is, why can't they work more? Because they were lifted from around 500,000 to 1.1 million shillings. So absenteeism is a big problem. It is not for us at the Ministry of Health alone. We are now calling upon you. Partly, that's one of the reasons we came here. Now, as one of the other things that we are doing is that we are going to form a standing order PC in 1 month so that you are paid. If your output is not measured, then you cannot be paid. Establish a governance structures. We've established governance structures like the rewards and sanctions, also the hospital boards and health unit management committees, which we actually request that you work more with, and we all fight this absenteeism. Now, there's a new form of absenteeism. One person works 1 week, another one works another week, so he works day and night 1 week, another one works day and night another week. This in health is very dangerous. Someone who is very tired can easily make mistakes, and a mistake in health is loss of life. So that is something that you also need to track when you go to the facilities. Ask for the duty rosters. If you see one person is working night the whole week, then you just know there is danger. I picked out some selected health indicators. Uganda is doing well in the region. I know it's a political season, people may want to water down what Uganda has done. And we are the only country in the region, actually in the world, that offers free health care. I usually tell people this because I'm a student of health economy. Uganda is the only country in the world that offers free health care that no one has paid for in terms of cost sharing. All the other, because of NRM, all the other countries you have to contribute through a system, including America. Now, the selected health indicators. This is one of our trends in delivery. Women are delivering in facilities. This is very good because I come from a reproductive health background. So as you see from the blue line, where we started from in 2000, only 37% of the women were delivering in health facilities. 37%. But right now, as we talk, 86% of our women are delivering in health facilities. Tremendous progress. Now, your role and my role is to help us and we reduce on this 14%. The yellow one, we are coming from 61, but we are still having 14. 14% of the women are still delivering in health facilities in the hands of TBS, traditional birth attendant. RDCs, there is an RDC of Budaka. I don't know if Budaka is here, but I want to thank you. I've never seen you, but we talk on phone. Budaka, you helped me fight that TBA who was killing mothers every day. Thank you so much. Asante sana. So this is delivery. Now, the interesting news is out of this 86%, 85% are delivering in government facilities. A vote of confidence that our government facilities are doing a great job. 85% of these 86 are delivering in government facilities. And this 86% is actually 1.8 million babies. You deliver 1.8 million babies per year. So you're doing a great job. Now, we monitor in the health sector, we're also interested in knowing how many women are dying. Around 2000, when we started serious counting, so many women in Uganda are dying. And this is the second to Tanzania. Tanzania is beating us slightly in terms of maternal mortality ratio. This is one thing, we don't want any woman to die while giving birth. But see where we've come from. We've come from 505 per 100,000. We count it per 100,000. For every 100,000 who are delivering, 505 were dying in 2000. But right now, only 189 are dying. 189 per 100,000. 189. The number is still big, but this is one of the best stories in Africa. This is one of the best stories on the African continent. Other than Tanzania, no one else has a better maternal mortality ratio than us. And our target by 2030, is to get to 70, where the rate is 2030.
During the Q&A
we need you.
Session.
Because there is a 14% that is still delivering under the hands of TPS, we cannot get to 70%. It's very difficult to get 70% when we still have people who are delivering in the hands of TBS. We are going to give you information. We are going to give you a leaders package to help us explain some of these things. What has led us to reduce this is technology and drugs. We have drugs that are available. Every woman who delivers has a potential of bleeding, and if a woman begins bleeding in a health facility, we have medicines to treat that. Also, the coverage of terms of health facilities has helped us to achieve this. So we need you to get to 70. 70 is the global target, and Uganda is on course. We can easily get from 189 to 70 if we work together collectively. Now, this is also another beautiful story, and I think it's always in the President's remarks. The government has done extremely well to reduce on the number of babies who are dying. In 2000, we had 158 babies dying per 1,000. This is for every 1,000, 158 were dying. For every 1,000 babies born, 158 were dying. But right now, we are at 52 per 1,000. This is also an interesting story, and Uganda achieved the Millennium Development Goal for this target, and we are on course to achieve also the Sustainable Development Goal. Now, the biggest problem is the green one. The green one is the newborn neonatal mortality. The babies who are dying before they make 1 month. That is still our big problem because we don't have facilities for looking after those small babies. But also women now, there's an increasing number of women who are delivering before 9 months somehow. pregnancies are not going to 9 months, either due to malaria or they are eating badly. There are many causes that are causing that problem. We can have that for another day. So these are some of the interesting stories that we have been getting. Our chair commented that you produce, I think Mr. Bashasha mentioned that you give birth to the number of children you can afford. Ugandans are now sensitive. They are only giving birth to 6 children. We are at 5 on average. 6 is still high to have the vision achieved. We think 4 is good enough. But we came from 8. We came from 8 children, now we are at 6, 5.2. This other trend is maternal health coverage. I liked this. This is probably one of the last. There is a problem. All the regions where you're coming from are not the same level of performance. Where there is red, this graph shows a composite indicator. We pick a few things and see where the other regions lie. If you can see properly, the average is 59, national coverage index, national coverage. But when you reach Kampala, where you expected healthcare to be very good, Kampala is doing badly, 49, it's the lowest. Busoga is doing badly, they are below 59. Bunyoro is doing badly. Karamoja still 56. North Central is, I am not so sure. North Central, it's either Kalangala. Acholi also 57. So, these composite indicators are defined somewhere. We want to see how many women are delivering under supervised care, how many women, children are coming back for immunization, and all those indicators, when we add them together, we see on average, how are you performing? So you see Bugisu is doing quite well, Ankole on the borderline, and the blue ones, as I mentioned. We still have another monster, as I mentioned, absenteeism. Young girls are getting pregnant. I was in Kasese yesterday, I found a 13-year-old. If Diana was here herself, she was going to cry. I know she cried in West 9. For her, when she's talking about these teenage pregnancies, she cries. Now, teenage pregnancy, a 13-year-old carrying a pregnancy, a baby carrying a baby is unacceptable. This cannot develop us as a country. For the last 20 years, from where we started counting, we have been the same. Young children less than 18 years getting pregnant. These are women who would be in school, who would be becoming the RDCs of tomorrow, who would become the important people of tomorrow, but they are getting pregnant. In Kasese yesterday, I found 13 years old, and there are many others who die because of complications related to birth. This is something that is sensitive to our cultures, but we need to fight it. I would expect a proposal about this. For us in health actually we receive the side effects. We are not managing, we are not at family level to see who is impregnating who. We are at the health facility counting. We are just counting. So this is the role of education, it's the role of gender, but health, we can offer them. So this is it's actually my last slide, and I want to thank you for God and my country. Thank you very much.
Join me to give a handful of clap for Dr. Mugati and Chris Mugarura for the able presentation they have been able to make. I know you have asked so many questions. We shall go like this. They will respond to the questions that you have asked in writing. Then, and only then, the 3 questions will come, one from there, one from here, only those that will not have been typed in those slides. Are we together? Allow me to welcome our senior citizen, a celebrated national leader, Mr. Daudi Mugereko, who came when you are presenting. You are welcome, sir. Okay, now you can come up here and respond to the questions. I can hold you. Come up. My boss of the time you're going to be standing.
Thank you, Chair. The first question is about 2030 target for ending HIV as a public health burden is about to approach. What is Ministry of Health doing to make sure that we address this situation, despite the increasing prevalence in some areas? We have done so well as a country to bring down the prevalence of HIV/AIDS, and we continue to do a lot. There is a presidential fast-track initiative that we are implementing, and we think that this will help us to reduce HIV in the other regions. The biggest problem here is behavior change. Now that we have ARVs, people have gone back. They no longer fall sick, the ARVs are available, so we need to intensify on messaging. We need to intensify on messaging because we need to keep people suppressed. If someone is on her ARVs or his ARVs and he has suppressed the virus, the transmission rate is very low. So where we are seeing increased transmission is majorly through the young people. We have a big problem with the young people, and as they mentioned that their pregnancy rates are also high. So probably the information has not reached there enough, but the old persons at least we are doing well. So we shall take that as feedback to make sure that we do more. What happened to the ambulance of Chavugimbi and new ambulances would come? There are 42 ambulances. There are 42 ambulances that are still at the Ministry of Health, and we want to apologize as Ministry of Health. Chavugimbi Bushenyi, I know the President was there a couple of weeks ago. These ambulances are going to be out. 10 of them are coming out next week, and the remainder will come out at once. So to be exact, by end of this month, or the first week of April, these ambulances will take Easter with us. There has been a long process to have the ambulance. There are 42 of them. So any question about ambulance, we received the ambulance, you returned it, you've never brought it back, is answered by that answer. The ambulances are coming out before the 15th of April, all of them. The first 10 are coming out next week, and the other 32 are coming out after. So that is Chavugimbi. We are finished. Now, ministry allocated money. This is very specific. I think Etuke Isaac, we can kindly talk to you before, after, at break time. It's very specific about the money and where it came from. So the specific ones, I will prefer that we engage outside before we leave. The facilities, someone guided me that if it's possible, we can have our dear leaders here verify that what we've presented, the pictures are actually there. And these are few. We've actually done so much more than this. So I think these pictures are there. So this was guidance. What are the requirements to upgrade the health center 4 to a district hospital? We are trying to avoid the word health center. From health center 4, you can't go to a district hospital now. And we want you to help us explain this clearly. From health center 4 now, you go to a community hospital. And I wanted to explain that one very briefly, community hospital. Community hospital is very good. It's going to have 60 bed capacity. Every time under 60 beds. Now the current ones are having like 20, some of them are even having 15. But now a community hospital is going to have 60 beds. It's going to have 5 doctors. It's going to have scan, X-rays, and modern lab. Scan, X-ray, and modern lab. So it's actually a community hospital. Those who have been to Windy, there's one in Windy, there's one in Rushere, something similar to that. 5 doctors from the current 2 to 5. The health workers, we are moving from 48, the current are 48, to 166. So it's, if we stock it well, it's actually going to work. So from Health Center 4, your name is going to be community hospital, and then the general hospital, like my colleague mentioned, is for only 500,000 people. Emitwara Atang. To general hospital. From community hospital, general hospital, regional referral. The government policy is very clear that each and every district should have a hospital. Now this hospital, you should add the word community, because the districts are too small. The district in Toroko has 70,000 people. So the districts are too small. Ministry of Health uses a population-based planning. So instead of remaining with the health center, we are enlarging the package for it to become a community hospital. So each district is going to have a community hospital. Each constituency, sorry, that can say about these districts minus hospitals. I think that's the same thing. Otuke, you are doing very well. Their health system is strong. Lubowa, this has been shrouded in so many controversies. Now the controversies are over. Lubowa, come December, I talked with the engineer before we came here. He told me 75%, the engineer. And indeed, the structure has come out. So I think it will be a very good timing for us to have a strong message. It has been very serious in terms of political issues around that. So Lubowa, I think I can't say more than that. So Lubowa is very sensitive. Thanks, Doctor. RDCs are not reactive to malaria and are not reactive to malaria. RDCs, no, this is not correct science. RDCs are very sensitive. They actually pick even where malaria is not. They can even pick malaria, another type of virus, another type of bacteria that's not malaria, and TBS, I'm not so sure what TBS is. The issue of study leaves, yes, this is the biggest problem. Study leaves are creating gaps. I was on the board of Port Portal Regional Referral. I found like 7 doctors had gone for study leave. It's a big problem. Now, the standing order that we are making for health workers is going to address this. The standing order. We are in the final part. We have taken it for the lawyer's review. The issue of health worker working in for more hours, yet it's not required. I think it's the same issue of absenteeism, the issue of cell health monitoring team not taking action, not giving feedback. I can't answer for the State House monitoring team because they are an independent body. But for us, we want to provide feedback. We want to work with you and ensure that everything moves well. Kindly request RDCs in this house about the national launch of malaria vaccines. Yes. Now, we started with 6 vaccines. Now the vaccines are 14. The vaccines are 14. All these vaccines are good. All these vaccines are good. They are safe and free of charge. Now, the most recent one is the malaria vaccine. Dear leaders, if we eliminate malaria, the money for income of households will increase automatically. Every household is spending not less than $200,000 or $100 every year on treating malaria. Because malaria, everyone can fall sick. If we are able to vaccinate the young children and they become malaria-free, we shall fight poverty very fast, and that will make us realize our dream. So I want to appeal that wherever the information is that we are going to launch the vaccination, kindly support this. Teso Cancer Center, the cancer centers are coming. I'm also from Port Portal, but I didn't complain. So the cancer centers, we started with 4. Now, our dear leaders, the issue of why we begin with phased approach is because of the limited envelope. And this one we have to always explain, because the community will always demand. When they hear hospital, the other side, they also want theirs. So the limited envelope. You have seen the blood bank has gone to Soroti, Hoima, Arua, and yes, those 3. The cancer centers have gone to Mbarara, Guru, and Eldira. Something like that. So what we do at planning level is make sure that there is a national representation and rational distribution of these centers. So Teso, it is coming. You have been suffering with blood, now blood has also come. Now you have enough blood. We have finished this one. Why is it that most health centers 3s and 4s are understaffed, and most especially in Eastern region? The issue could be around, it may not be actually understaffing, it may actually be the study leave. I went to one district, actually in Toroko. In Toroko, one person went for study leave, he finished 5 years, after 5 years went for another study leave for 2 years, after 2 years went for another study leave of 1 year. When does he work? Toroko is here. RDC, kindly help us. Toroko, if you are here. There is someone who went for study leave for 6 years. After 6 years, went for 3 years. After 3 years, went for 1 year. That is 10 years. That is 10 years. And this is happening in all your districts. In all your districts, this is what is happening. The relatives are releasing their children to come, and it's a mess. It's not coordinated by Ministry of Health. Because of the decentralization law, these are managed at district level. Sir, in your presentation, did you say that you install oxygen in all referral hospitals? The beginning of Feb, 5 people lost life in Moroto. Moroto, do we have an oxygen in? Okay. I will double check. I don't remember well. But we installed, what we mentioned here, we installed 48 oxygen plants. And the country now has enough oxygen. So if Moroto did not have oxygen, then they can get from national medical stores. I will double check in the presentation. So the 48, I may not know exactly if Moroto has, but we can also discuss that. I can call directly the director in Moroto and we find out. The 5 people who lost life, that's very unfortunate, but no one in Uganda should die because of lack of oxygen. Oxygen should not be bought. Don't allow to buy oxygen because it is free. It is taxpayers' money. The cost of CT scan is prohibitive too high. Yes, we didn't mention that. We decided, and it's a consulted position, that for us to maintain these CT scans, we put a user fee of that's 120,000. We know it is high, but the directors have a discretion of whom to waive. If someone is very poor, they can waive. But because they can waive. But because where we are coming from, as leaders, you need to know where we're coming from. When I was training as a doctor, there was no CT scan in Uganda. It came when we were in Makerere, we got the first CT scan, and it was 800,000 per scan. Now, the CT scans are in every region. That is NRM at work. And that's a very strong point. CT scans are in every region. Not only CT scans, now we are beginning state kidney services. Hoima, you are beginning a kidney clinic. This is renal dialysis in Hoima. We've already started in Lida. Masaka has started. We are taking all these services to the regional cardiac, the heart, the kidneys, and all those things are coming. So on that cost, for us to maintain the equipment, because we have a risk of also giving it for free and it fails to work. We fail to get money for servicing them. But we can discuss that. We can take it as feedback for government, see if they can completely waive it off. Soroti Regional Referral, City Constituency Ambulance Week, ambulance I had finished. How much money are patients supposed to pay for referral ambulance? This is a local arrangement. Referral is supposed to be free. The ambulance is free. The fuel is the problem. We mentioned we give these ambulances 2.5 because that is what we have. We are giving them 2.5. From Fort Portal to Kampala, the ambulance consumes 100 liters. That is 500,000. So meaning that it will only carry 5 patients, realistically. We are aware about this, but we also want to inform you as leaders that the money we put on the fuel card is not enough. There's a good innovation in Kamuli. The district, the health facilities combine their money. They collect some money from the health facility, from what they receive as health facility, and make a pool of fuel, and they are doing well. So this one, for ambulances, especially the expectant mothers, ambulance referral is free. Only fuel is the challenge. Budaka has no hospital, but has one health center for serving a population. Yes, Budaka, your health center for is very big. Considered for community hospital as fast as possible. Budaka, I know. Your health center for is very big and it has very many deliveries. There are many challenges. There are plans to upgrade to a community hospital, not to a... The indoor management of mosquitoes system has reduced mosquitoes and malaria in the West Nile. True. How come some districts have been left out? The same answer, it's very expensive. We begin with targeted areas of high burden. Targeted areas of high burden, the others when we get money, actually it was a USAID supported activity. We may not spray anymore, to be realistic, because the money was coming from the Americans, unless they give us more money. But the mosquito nets are doing a great job. I was in Kabarole they want to return all the coatem. In Kabarole, they want to return coatem and testing kits. They have tested malaria using mosquito nets. Please explain why it's on duty. The others, if I miss your question, we can talk outside. The building on the oxygen plant in Yumbe Regional Referral by the Engineering Brigade UPDF has stalled. No oxygen so far. We shall follow up with this oxygen. The follow-up will take the other side. Is it a policy for the Ministry of Health for health facilities, especially rural ones, not to operate during weekends? No. The standing orders are going to rectify this. This one is coming to an end. They had given themselves so much leave, but we are going to end it with the standing orders. How many hours should health facilities open? Also in the standing orders. Who is authorized to call a health worker during the night? DHO, even RDC. RDC, you're a very big person. You monitor all government services. You can call anyone, including the DHO. Have I taken long? I can summarize. Palisa has a broken down X-ray. Yes, Palisa, yes, we are aware, and has been planned for replacement and Chenjojo, hopefully. There are some X-rays that we have bought. They are coming in, I think, in the next 3 weeks. COVID-19 vehicles were ejected. This is very true. Now this one is not ours. We have tried to, COVID-19 vehicles for DHOs were ejected by LC5 chairperson, RDCs. This one you need to help us. They are not here, they would be answering. But we've recovered some of them. And now the current policy is actually to park them. We bring them and park them at the Ministry of Health. They still have a number plate, so they belong to the Ministry of Health. Uganda has never done best doctors, researchers. What is the mechanism in the Ministry of Health in place to ensure that they are fully in charge of our health? We've improved the payment. We are the best paying country in the region, paying doctors. So those who can work for government, they will remain around. So we've improved on the payment, and that's one of the ways of retaining your best talent. This handwriting is very tough. What is the ministry's strategy to ensure that the contracts are performed on time? Contracts performed on time, these contractors who don't perform on time, UPDF is coming. UPDF is coming. So as we build capabilities in UPDF, then we shall have everything. I think we have finished. There are many. Clarify on some of the districts that have not received their ambulances up to now. This is finished. Ambulance, finished. Agago, your ambulance in the next 3 weeks. If it's among the ones coming out next week, it's good. How to know which ones are coming out next week, you can consult me, I'll give you my number. Medical bills, very high cost, especially at referral level. Medical insurance scheme. Medical insurance scheme went through Parliament. I think it can't come in this Kisanje because there was a lot of back and forth and consultations, and now it's before the Fountain of Honor. It may not come, it may come, it may not come, but most likely it's not coming. What are the plans for upgrading Bujiri? Bujiri, we can consult. We had gotten money to upgrade your hospital to a very good hospital, Bujiri. I can consult if the money is still there, but it was a loan from the Islamic Bank. Reduce cost of referral to Mulago, especially Mulago Hospital. We are doing this. The moment we have regional referrals having ICU, regional referrals having all these other services, then there will be no need of leaving Masaka coming to Kampala. Kampala will be less congested, so that will reduce the cost. Kabramaido General Hospital has less number of doctors, which leads to patients. They must have run away. This one will need an intervention. We shall follow up. RDC Kabramaido, we shall follow up. Sironko, is it in order for how to promote DHOs whose national performance is poor? These are our problems. These are our biggest problems, and actually the last national assessment, 26, these are our biggest problems. There is a lot of corruption in selling. Please, RDCs, the jobs in districts are being sold. We have a cancer. That's a cancer that might eat this country. I'm told in some districts, becoming a nurse, you pay 7 million, becoming a clinical officer, 15. So this is a cancer that must be fought. You are leaders, you must get the solution. The whole health system in Soronko is going down. We may need special attention. We shall follow up. Soronko needs follow-up. I usually put Kapsoro and forget them. Paita Health Center 3 was among the 24 to be upgraded to Health Center 4. The upgrade of Health Center 3 to 4 is going to be gradual. Now we've picked around 24. Because of the money that we are given, and now you see we had a challenge of the Americans withdrawing their money. Huh? We shall put it. The list is big. The list is actually big, but not on these 24. So next year we shall put others. Mayuge district has no hospital. Why? This one has been answered. Community hospital, you'll get 3 of them. 3 community hospitals are better than 1 hospital. Mayuge. 3, you have Chierera, you have Mayuge, you have Chigandalo. Those are 3 community hospitals. You'll have better services and better coverage than 1 hospital. There are many clinics, drug shops run by quacks. Very true. This work is not under Ministry of Health, it's not under National Drug Authority, but we can take the feedback. It's very true, we are aware, and some of them are just killing our people. There is a doctor in the East who stole a patient from a mother from the hospital and took him to the private clinic and he died. Mbale district has 1 health center, 4 and no district hospital. Mbale district. Yes, Busiu, I think that's Busiu. Okay. I think the answer of hospitals has been answered. Now, dear leaders, I thought these were coming from politics. They are NRM chairpersons here. Okay. RDCs, I think the ones that are coming for requesting for hospitals are from. Let's get the same general understanding that the health center force are going to become community hospitals. And one of the intentions that we want to tell you as leaders was to make sure that because the hospital will be far, even if you put 1 hospital in Mbale, it will still be very far. I know the geography of Mbale. It will be far. But if you have 2 health center force, one the other side and this one this side, called community hospitals, with those service packages, they will serve a better population. Serious concern, sometimes medicines are hidden from common people and it may be given to civil servants. With the current stocks we have above 80%, medicines hiding might be